Good afternoon or good morning, and welcome to this GSA webinar, The Intersection of Obesity and Obstructive Sleep Apnea in Aging and Older Adults. We're so excited to have you here today. We have a few housekeeping items to go through. We will have Q&A at the end of the moderated discussion, so we welcome you to type your questions in the Q&A box at any time during the webinar. Our program today is being recorded and will be available on demand in GSA Enrich by the end of today. And your feedback is important to us, so please do complete the evaluation following the webinar. And we'd love to hear from you of other topics you'd like to learn more about related to today's program. And I'd like to take a moment to introduce my colleagues who have joined me on the phone for this on the webinar for this discussion. Dr. Monica Malampalli is a patient with sleep apnea and is a trained biomedical scientist and the president and CEO of the Alliance of Sleep Apnea Partners, or ASAP. Having experienced challenges in treatment following her diagnosis with obstructive sleep apnea a decade ago, led her to her current role at ASAP in advocating for those who suffer from sleep apnea. Besides being a patient advocate, she also brings unique perspectives to conversations, drawing on her 15-plus years of research and health policy experience. Dr. Malampalli was recently appointed to the American Academy of Sleep Medicine's Women and Sleep Health Task Force. We're also joined by Jennifer L. Martin, who is an endowed professor and director of the Benjamin Leon Jr. Family Center for Aging Research and Education at Florida International University, and the director of the Miami VA Healthcare System Geriatric Research, Education, and Clinical Center. Dr. Martin's scientific research focuses on improving sleep as a key component of maintaining and improving physical and mental health in older adults, women, and veterans. Her work has been supported by NIH, VA, industry, and nonprofit foundations. Core areas of her work include developing and testing novel approaches to treating insomnia disorder, improving the use of sleep apnea treatments, and understanding how improved sleep leads to health benefits. Dr. Martin is a national leader with a strong record of service. She is a past president of the American Academy of Sleep Medicine, and recently received the VA's National Health System Impact Award, recognizing the impact of her research on healthcare for veterans. And finally, we're joined by Dr. Christopher Schmickel. He's an associate professor and sleep medicine specialist at UC San Diego, whose work centers on advancing new therapies for sleep apnea. He's received NIH, AHA, and AASM funding to lead clinical trials evaluating promising pharmacological treatments. As director of the Advanced Care and Electrostimulation for Sleep Apnea program, he provides patients with new therapy options such as hypoglossal nerve stimulation and tirzepatide, particularly for those who struggle with sleep apnea use. With CPAP use. His goal is to broaden the range of effective individualized treatments pathways for sleep apnea. Please do send us your questions. We welcome you to click on the QA icon located on your Zoom dashboard and type in your questions. And so let's get right into our discussion with our panelists. Again, I just want to welcome everyone, and I'm so grateful that GSA has this opportunity to partner with the Alliance of Sleep Apnea Partners on this important topic of the intersection of sleep apnea obesity. We appreciate Lily's support for the program. Although sleep apnea is estimated to affect over 54 million people in the United States, many cases remain undiagnosed or undertreated. Obstructive sleep apnea is the most common sleep disorder. Even more alarming than the number of people facing sleep apnea is the number of adults living with obesity in the United States. Currently, more than 100 million adults have obesity, and 1 in 5 of these adults have severe obesity. Many adults with obesity have other serious chronic diseases. For example, 58% of U.S. adults with obesity have high blood pressure, approximately a quarter have diabetes, and up to 45% have OSA. So I'm pleased to welcome Dr. Malampalli, Dr. Schmickel, and Dr. Martin here with us today. Welcome to you all. And again, thank you so much on behalf of GSA and ASAP for joining us. Dr. Malampalli, please get us started by sharing a bit about the prevalence of OSA among adults and how that prevalence changes as we age, and a bit about the relationship between obesity and obstructive sleep apnea.
Thank you, Jennifer. And first of all, I also want to thank you on this partnership with ASAP. So we're pretty excited to be here today and look forward to continued work with GSA. A little bit about the prevalence of obstructive sleep apnea in adults. So like you mentioned, we believe there are over 54 million adults who are living with obstructive sleep apnea, but I think the numbers may even be higher because we really don't know the true numbers. And I think over the years, we've seen an increase, and I think the estimates go up to even 80 million. So again, we don't know. But one thing I think what the research indicates is it does increase with age, almost seems to plateau off after the age 60, which also makes us believe that perhaps we're not really picking up adults, older adults who may have obstructive sleep apnea or have symptoms of it. We see it's much higher in men, but when women reach menopause, their risk for obstructive sleep apnea is equal to men. We also know that often women go missed with the diagnosis of obstructive sleep apnea. So this is something that we certainly want women to know and ask their doctor. And I'll get back to this later, that perhaps to even understand that they could be having symptoms of obstructive sleep apnea. Now, why does this prevalence increase as we age? Because, there are a lot of age-related physiological processes that happen, which also contributes to obstructive sleep apnea. And these can be very similar to, again, what we see in obesity. So some types of physiological changes you see is deposition of fat around the tongue or, around the upper airway, which actually limits a person's ability to breathe, and causes, the severity in obstructive sleep apnea. Now, there is a relationship between obesity and sleep apnea, and this tends to be bidirectional. That means each of them influences the other. We know about 69% of adults with obesity have some form of obstructive sleep apnea, and I believe about 32% have almost like moderate to severe sleep apnea, and this is measured by something called the apnea-hypopnea index. So obstructive sleep apnea by itself can cause weight gain. And then excess weight can then make obesity, obstructive sleep apnea severe. But again, that obesity risks can increase by driving hunger or, leading to insulin resistance, etc. I'm just reading this data point that I usually mention is that an individual has 6 times a higher chance of developing obstructive sleep apnea with a 10% weight gain. So there's an increase in weight, there can be an increase in severity of obstructive sleep apnea. I do want to mention something for the audience to understand. Not all people with obstructive sleep apnea have obesity. So that means there are certain factors that are at play here that can lead to obesity in patients with obstructive sleep apnea. And again, that is not the scope of the discussion here today, but just wanted to make sure that and the other point I want to make sure when someone living with obesity does try to lose weight or manage their condition and cannot assume that their obstructive sleep apnea will go away. This is something they always have to be on the lookout for. And this is sort of something we always bring up and discuss with people. And I'm sure the experts here can weigh in more about some of that information.
So, Dr. Malampalli, in follow up to that, what do the risks, particularly as we age and older adults, what kind of risks do they face in particular with sleep apnea, particularly if it remains untreated?
I think in general, we know based on the literature that adults with obstructive sleep apnea are at risk for the same conditions that people living with obesity have, such as cardiovascular disease risk, type 2 diabetes, hypertension, conditions such as atrial fibrillation, AFib, heart failure, cognitive decline, Alzheimer's disease. So I think my understanding is when you have both of these conditions, I believe there will be a synergistic effect and kind of much more increased risk towards these conditions. And again, I think there's quite a bit of research around this, but we also need more research and understanding these connections and links.
Right. Well, Dr. Schmickel, Dr. Malampally mentioned this relationship, kind of bidirectional relationship with obesity and OSA. How does that relationship change as we age?
Yeah, it's a good question, and I think Dr. Manapali really laid it out pretty nicely there. I think the one thing I just want to add on a little bit to that is that I think the relationship between obesity and sleep apnea is very clear. We know that about 50% or maybe 40 to 60% of obstructive sleep apnea is attributable to excess body weight. And that's probably like related to like this, upper airway narrowing, tongue fat, and all those things. So obesity certainly, in that direction affects sleep apnea. There's no question. The relationship between sleep apnea and obesity is a little bit more complicated, where like, yeah, there is some data suggesting that, patients with obstructive sleep apnea, it disrupts like the hunger hormones. So ghrelin, for example, which is a signal for hunger, kind of goes up. There's some leptin resistance, where leptin usually likes, is a marker of satiety. But on the other side, when we look at meta-analysis of clinical trials of people treated for the sleep apnea with CPAP, we actually see that usually like the weight doesn't really change much. If anything, there's actually a slight signal for maybe like people gaining a pound or two or so after starting CPAP. And so there's some thinking that maybe, like that struggle of that, over and over choking in your sleep during the night may actually also cost quite a bit of energy. And so now by treating this, now you kind of, reduce some of that energy expenditure. And so the net effect then is kind of close to neutral or so. But I personally still think, anecdotally, I think I have seen some patients where like, treat the sleep apnea, they feel better, they're more energetic, now that's also for them potentially easier to kind of, implement healthy lifestyle, more exercise and so forth. And so now the question is, and how does it change with age? Certainly obesity does remain like an important risk factor for sleep apnea even as we age, but the relative contribution probably does go down a little bit. You can see that, for example, like even patients or people without overweight or obesity, the prevalence starts going up as we age. And that's probably related to age-related changes of upper airway anatomy, neuromuscular control, ventilatory control. For example, there's also, other comorbidities become more prevalent, like heart failure, atrial fibrillation, which can lead to some ventilatory instability, which can contribute to sleep apnea pathogenesis. Or there's also potentially changes like in fat distribution where, not every BMI is equal. If the fat is maybe more in the tongue, that might be more significant for the sleep apnea pathogenesis. There's changes in sleep architecture. There's like more light sleep or so where people might be more vulnerable to having like sleep apnea. And then there's probably also some survivor bias where, people with very severe sleep apnea and obesity, may not kind of survive towards that age. And so that changes in the distribution there potentially as well.
Sure, thank you. Dr. Martin, what else might impact sleep in older adults with obesity and OSA or obstructive sleep apnea?
Yeah, well, I think Dr. Schmickel started mentioning some of these things, but there are some age-related changes in sleep that are independent of both obesity independent of obstructive sleep apnea. So an example is that we do see additional changes in sleep architecture in older adults with obesity, specifically less REM sleep, which might be associated with learning and memory and things like that. We see that even separate from respiratory events, that older adults have more sleep fragmentation, so they wake up more often, likely because they spend more time in light stages of sleep than younger adults. And that seems to be even more pronounced if they have comorbid obesity. It could have to do with things like comfort and body position. And even if a person doesn't have what we would technically consider sleep apnea, it just may be a little harder to breathe while you're asleep if you're carrying excess weight. So it just might be a less restful period for the body. The other thing is that specifically in women with obesity, independent of obstructive sleep apnea, older women with obesity seem to sleep less than older women without obesity. Unfortunately, we don't know if that's because they may have other sleep disorders like insomnia or restless leg syndrome or things like that. We do see this shortened sleep time in older women with obesity that we don't see in older men.
Interesting. Well, as we, all of us age, we are certainly working toward age-friendly health systems. And the 4Ms framework that's used in those age-friendly health systems bring the clinical team's focus to what matters: medication, mentation, and mobility for each older adult. So Dr. Schmickel, what outcomes matter most for older adults with obesity and sleep apnea?
Sorry, it took me a moment to find that unmute button there, but it's a really good question. And generally, I feel like in terms of benefits, the focus in my older patients is often a little bit more on quality of life. But it's really, really important to individualize that. I have some patients, they're still, very focused on like the health outcomes and the cardiovascular outcomes and so forth. And we recently actually had sent out a survey, kind of trying to get a sense, what is the information that people need in order to decide whether they want to start with CPAP or tirzepatide or kind of combining those. And the results really suggested across the board that, a lot of information is important. Like people do care about symptoms. They do care about like what's the impact on the sleep quality, sleep architecture, cognition, and cardiometabolic outcomes. To me, it seems like there's no clear difference between ages, but again, it is a very individualized decision there. For me, usually like with my older patients, in general, there's always like you have to weigh the potential benefits against the risks. And I feel like with my older patients, I do emphasize the potential risks even more so, trying to focus on the safety and also like considering the treatment burden. And so, you have to, for example, think about, with the CPAP, for some people that may work really well, but some people may kind of not have the dexterity to kind of put on that mask. So then the question is like, do you have someone to help you with that? Or like with tirzepatide, this weight loss medication now, which is very effective, some of the risks might be more pronounced now. Like if you have like some dehydration, you get dizzy, you may have a fall or something. So kind of keeping that really in mind and kind of really not ignoring the safety there. But at the end of the day, it's really like, what matters to you? What is important to you? What are you trying to achieve here? It's usually a very long discussion that I have with my patients.
That's terrific. And you mentioned a couple of considerations, like the ability for the individual to function well enough to put on their treatments and looking at risk benefit. But as you think about other treatment choices in older and aging adults, are there other things when they have obesity and sleep apnea that you might consider thinking about treatments?
Yeah. I mean, usually like with my patients, I should maybe also say like I do focus a little bit more on patients who kind of usually fail CPAP. And so then, we often the focus is on reviewing like all the alternatives or so. But in general, I try to kind of make it a point that, really kind of first trying to decide like, should we actually treat, kind of really going through like, okay, how severe is your sleep apnea? What should we worry about it? We mentioned a little bit about, sleep apnea has been associated with a lot of adverse outcomes, but really the strongest data that we have is usually from clinical trials is like improving symptoms and lowering blood pressure. And so, in my practice, I have a pretty low threshold to offer people like something like, try out like a CPAP and see if that helps you feel better or so. But I have a pretty high threshold to send someone for like a surgical therapy, for example. And especially, again, this would be more pronounced in my elderly patients. In general, CPAP, I think, is still the first line. If it works for people, it is the most effective therapy we have and pretty safe. Again, for elderly patients, does come with the caveat of, are you able to kind of put this on or do you have the support? Sometimes if there's some dementia or so, on one side, like, yeah, with mild dementia, it may actually help people maybe to be more alert, more focused. And so, but I do worry if, dementia is more advanced, do I actually like now cause harm in the sense that, someone is just, struggling with this mask, is getting more confused, getting more aggravated or so. So I think you have to be very mindful of something like this. And then, yeah, weight loss, still, I think in patients, even elderly patients with obesity can be very helpful, can have huge health benefits beyond just the sleep apnea. But again, also have to kind of look at potential downsides of sarcopenia, muscle loss, risk of bone loss, and so forth. Again, mentioned, there's oftentimes, generally tirzepatide is well tolerated, this weight loss medication. But for example, GI symptoms or side effects are common. And, a younger person might be able to kind of just stay at home, hydrate, and be okay. But an older person, again, like dehydration from nausea, vomiting, might quickly lead them to renal failure or fall or something like that. So you have to be more careful. And so when I consider this kind of therapy, I think I pay a particularly great attention to lifestyle changes like diet and exercise. The idea being that in order to minimize the muscle loss or so, it's really important that you have enough protein intake, that you include some strength training in your routines and so forth in order to kind of maximize the fat loss while minimizing that muscle loss, and then very close follow-up, kind of making sure you check in and so forth. You mentioned there's some other therapies out there. I don't want to go too much in those, but yeah, oral appliances you can still consider. Caveats there is like, you have to have a good dental status in order to qualify for some of this. And then again, beyond this, there's like some surgeries. But again, I generally would be a little bit more careful with those as patients age also advances. But it's a very individual decision for each one.
Dr. Martin, Dr. Malampalli mentioned some differences between men and women, but I wonder if you can talk a bit more about differences between older and aging men and women with obesity and OSA, and really how does that impact treatment, kind of the implications of treatment for that?
Yeah, so I think there are 2 points I'd like to make. One is that I think sleep apnea is more likely to go undiagnosed and untreated in women compared to men. And part of that is that sometimes women don't present with the same symptoms that physicians are used to seeing. For example, they may not come in and say, the person that I share my bed with says I snore and I'm sleepy all the time. And these are biological differences. They're not just psychosocial, especially sleepiness. So women seem to be able to stay awake when they're sleepy more than men. And that's a lifelong difference between men and women. So what we hear from women is things like fatigue, low energy. I've had a number of patients describe to me that when they came in and talked about how they were feeling, they got put on an antidepressant medication. And it wasn't until much later in life that they got their sleep apnea addressed. So I think one of the main differences is that providers shouldn't assume that just because a patient is a woman, that she doesn't have sleep apnea. And especially, and Dr. Malampalli mentioned this, after menopause, the rates of sleep apnea go up dramatically in women, whereas in men, they tend to go up in a more linear fashion with age. Since most women experience menopause in their early 50s, that change actually happens in kind of younger, older people. And if it goes untreated, it really increases the risk of some of these, what we think of as diseases of aging, things like type 2 diabetes, heart disease, which of course, if a patient also has obesity, those risks are amplified even more. So another difference is that women tend to have milder sleep apnea using the way that we define sleep apnea events now. And so sometimes we have to be thoughtful, because even with mild sleep apnea, women can have more severe symptoms during the day. They may not be that classic falling asleep driving, but they tend to have more severe symptoms. I feel like there was a second part to your question and I may have missed it.
Just what those differences mean for treatment.
For treatment, yes. So coming back to what matters to patients, I actually love to start my interactions with patients by asking them how their sleep disorders is affecting the things that they care about most. So of course, there are some things that are very individualized, some things that tend to be different between men and women. Statistically, women are more likely to be caregivers for their partners. And that's a very important role for a lot of older women, is that they're helping to take care of their spouse or their partner. So being mindful about treatment decision-making based on what's important to the person and how they perceive their sleep apnea affecting the things that really matter to them. I think that's really important. The other thing to consider, again, is because women tend to have milder sleep apnea, they may have a larger range of treatment options available, including what Dr. Schmickel mentioned, oral appliances, because men tend to have more severe sleep apnea. Some of those treatments might not alleviate the severity of their sleep apnea or their symptoms as much. But in this way, I think women might have more options available to them for treating the sleep apnea.
Great.
The last thing I will add, I can't resist as a clinical psychologist, is that women are more likely to have both sleep apnea and insomnia disorder than men. And so sometimes, even if we treat a woman's sleep apnea, their sleep doesn't get better because they have another sleep disorder layered on top of it. So I think we have to also be mindful that just because a person has sleep apnea, that doesn't mean it's the only sleep issue that they have. Obesity is associated with having more insomnia in addition to having more sleep apnea. So that's something we have to keep in mind. And again, there's a sex difference there where women have more insomnia than men as well.
Very interesting. Oh, Dr. Malampalli, you're on mute.
I just want to add something to what Dr. Martin just said. Even coming from the women's health space, I often hear about women complaining that they have insomnia, and this is not a formal diagnosis. And I often find myself telling them, "Are you sure you have insomnia? Have you had a sleep study done and confirmed?" It's possible they have sleep apnea or both. So I think it's very important for women to understand that instead of just assuming that they might have trouble sleeping or perhaps have insomnia, it's important to have it checked, talk to their physician, and then get the right diagnosis. So just wanted to add that.
Great. One of the special things about our organization, GSA, is that our members are very interdisciplinary. We hear the number that they come from 26 different disciplines. So, Dr. Malampalli, I'll start with you, but I welcome all of you to chime in on this question. Who are important members of the interprofessional team for the care of older or aging adults that have obesity and obstructive sleep apnea? And what are some important roles for those team members?
This is a good question. I think just like you mentioned, your members come from different disciplines. I think a sleep apnea interprofessional team can also be very interdisciplinary. I mean, the condition is as such, right? We have, just like, if people living with obesity are seeing cardiologists, they may be good at diagnosing sleep apnea. So it's worth having that conversation with doctors from other disciplines. So let's say, neurologists or cardiovascular disease specialists, dentists have become an important part of diagnosing people with obstructive sleep apnea. And I think especially when they have, again, they're very good at that. So I think there is just a mix of different people, but importantly, I think they are certified in sleep medicine, coming from different disciplines. And I would definitely, defer to Dr. Schmickel more about that, because I think his background is in internal medicine, and Dr. Martin too. But I think it's important to remember that people can talk to other specialists as well if they do suspect that they might have obstructive sleep apnea, especially if they're, living with obesity.
Great. Dr. Schmickel, do you have anything to add about interprofessional colleagues that you might call on to support, and Dr. Martin as well?
Yeah, I think it's a very good question. I think one thing I love about sleep is that it's very interdisciplinary. So for example, like in my practice, I work very closely, for example, with an ENT surgeon for patients who are considering surgery. I used to work very closely with our weight management specialists until I kind of started doing some certification myself, and now I handle for the most part that. But I'm always happy that I can rely upon them if there's any questions. Personally, I almost feel like the sleep field is so young still, and there's actually so many different disorders. Right now we're just talking about sleep apnea and insomnia, but there's REM behavior disorder, narcolepsy, and so forth. So there's a whole spectrum. So I almost feel like at some point in 100 years, I wouldn't be surprised if you have kind of almost like a PCP for night, and then you have specialists for the different things. Because the truth is that even though I know a lot about sleep apnea, for example, I'm the first one to admit that if I have someone with a very complex respiratory hyperventilation disorder, I'm very happy that I have my colleague Dr. Orr, for example, who's a pulmonologist who's an expert on this, or a very complicated neurologic disorder, kind of working then with if there's seizures, epilepsy, for example, working with a neurologist there. So yeah, I think being aware of your limitations is important. Having colleagues that you can rely upon is important. And, there's different, I think I've seen like some primary care doctors, for example, they are very competent managing a lot of the sleep apnea, and others, they have like such a broad practice, they rather than, focus on other things maybe, and then are more happy to hand over their patients to the sleep clinic, which I think is totally fair. So everybody has to find out like where they're comfortable with, I think. But generally having more awareness about sleep, screening for it, and then making sure people get the help that they need, I think that's a critical part there.
Great.
Jennifer, if I could add one comment, and I think, Chris, you
Please.
just touched on it, and it might be the most important thing for this audience, and that is I think every healthcare provider has the ability to identify a patient at risk for sleep apnea and get them on the right path. I'm always surprised by how infrequently even primary care providers even ask about sleep. And I think that if you're a nurse practitioner, if you're a social worker, if you're a marriage and family counselor, that all members of the healthcare team actually have a responsibility to get this conversation started. We know that people in general and older patients in particular don't bring up their sleep issues to their provider until they're really, really impacting their quality of life. So we all share responsibility for that screening. And then I think when we don't have those really clear cut, this person is at risk for sleep apnea, I know what to do, those folks benefit most from referral to a sleep specialist, someone who's board certified in sleep medicine, who can really take a broad look at all the potential causes of a person's symptoms. As Dr. Schmickel said, we've been talking about sleep apnea. We kind of mentioned insomnia and a couple of other things, but it's really common for people to have more than one sleep disorder. So I just kind of wanted to point out both ends of that spectrum, but really for this audience that, we all can just ask, how are you sleeping? To get that conversation started.
So I was going to ask that when you talked about, we all can screen. So I'm a nurse, and if I'm that nurse interacting with my patients, do I ask, how are you sleeping? And they say, not very well. And then what's my next move if I'm not a physician, if I'm not going to refer to one of you guys who's an expert? What do I ask next? Who do I tell them to follow up with? What's my best course of action for our social workers and people on the line?
Yeah, right. I mean, that's a great question. I always just say, tell me more. And then, now anyone who's come to this talk knows a little bit about the signs and symptoms of sleep apnea. And if you suspect that, you can always try to connect them with the right provider. If you're not a referring provider yourself, you can encourage them to talk to their primary care provider. And I coach patients in what to say. If they really do want to get seen by a specialist, I say, I think I might have sleep apnea. Could you please refer me to a provider who can help? So I think, there's that tell me more question. And then, as Dr. Malampalli mentioned, sometimes all patients know is the symptoms that they're experiencing, but really, empowering them to ask for a referral to see the right specialist.
And I just want to add, anecdotally, what we've heard is patients who've been diagnosed with other chronic conditions, such as AFib or cognitive decline, have then found out that they had untreated sleep apnea for a long time. So it's like they're learning from other, or other specialists that perhaps they, were never diagnosed. So I think it's just important for physicians, and we encourage physicians to come into sleep medicine and get board certified in sleep medicine, because I think, again, as Dr. Martin said, there's so many other sleep disorders too. But just having that additional understanding and being able to talk to their patients and encourage diagnosis, I think is so important.
Yeah, maybe just one more comment on that. I think, even if you're anyone who talks with a person who kind of shares with them that their sleep is not great, I think even if you're not sure what the right next step is, or so, just kind of emphasizing that this is serious potentially, and so to kind of potentially really bring this up and seek some help for that. I think we talked about earlier in the statistics or so, we think that up to 10% of people have moderate to severe sleep apnea in the United States, but only about 1 in 5 of them is actually diagnosed with it. And a lot of this is probably related to people not really knowing about it, the providers maybe not really screening well for it or so. And so I think, kind of empowering people to kind of seek the help that they need is one part. The other part I suspect that often is like an inhibition is that, people, if they snore, they kind of heard about sleep apnea, they heard about CPAP, they're like, I don't want to wear a mask, so I rather don't bring it up. but maybe also letting people know that there's a lot of change. There's a lot of different options. CPAP, yeah, it's our workhorse, but there's alternative options potentially. And so go get an evaluation, hear about what the options are. If you still don't like it, you don't have to do it, but there's a chance that you might be missing out on some benefits, some real benefits you could be getting.
Great. Well, the next question I want to ask, I'm really excited because I have three very unique perspectives with the three of you. And so what I'd like to talk about is the issues around, what important issues around provider and patient communication and patient education for aging and older adults with obesity and sleep apnea. And Dr. Malampalli, I'm excited that you have a patient perspective, and Dr. Schmickel has a specialist perspective, and Dr. Martin works with veterans and in different places as well, and as a researcher. So I'd love to start with you, Dr. Malampalli, but hear from all of you about your perspectives that you bring to the table.
Well, thanks, Jennifer. I think let me just address the patient education. I think it is so key to provide education to patients. And we've touched upon some of these things in the discussion. So at ASAP, we encourage self-advocacy. We want patients to understand what are the symptoms, what are the risks, how to talk to your providers. And more importantly, something Dr. Martin briefly touched upon is the bed partner, who plays such an important role in helping with diagnosis for sleep apnea. I mean, you have to remember the patient is sleeping, they're snoring, they're gasping for breath. They don't realize that, that they are not the ones getting, they're not getting oxygen while they're sleeping. They wake up tired. They think they might have slept well, but they see the symptoms in the morning, but who notices it is the bed partner or a caregiver. So I think it's important to bring, not only give the education to the patient, but also to the family members. I think it's important, family members or caregivers, to understand that this is a serious issue. And as for the provider-patient communication, again, taking your partner with you to these appointments, because again, they can provide additional insights into what the patient might be going through. And often I think, and we've heard again anecdotally, and I don't know, I think there must be some literature there that it also affects relationships at home, relationships with the bed partner. So it's not just the patients who's impacted by it. This is their whole family that's impacted by, not addressing obstructive sleep apnea. So I think those are the types of things. And I think when you go in for provider-patient communications, we are trying to come up with toolkits that encourages certain conversations, like what type of questions do you ask your physician? And it's possible sometimes physicians know about sleep apnea and sometimes that they don't. And especially when it comes to addressing sleep apnea in women, most physicians still to this day, at least primary care, will think that it's only men who have sleep apnea. So I think there's more important for women to bring it up and say, can you get me a home sleep test? Can I go get tested? Now it's easy to get a home sleep test than trying to wait months to get into an in-lab, sleep study or at a hospital. So I think having that little bit of that understanding and questions, and then to also what Dr. Schmickel said, there's so many treatments available now. People just get put out by thinking, oh, I have to use this thing, a mask, which we have a lot of data to show CPAP works really well. But if somebody is intolerant to CPAP therapy, there are options available. And I think patients should be asking those questions. Okay, let me get diagnosed. And if I have diagnosis, what are my options and what do I do next? And there are sleep specialists who can help you with all of that.
Right. Dr. Schmickel, how about advice from you as a specialist? What do you focus on important communication points that Dr. Malampalli hasn't mentioned?
Sure. I think for me, that education part, there's two major parts to it. One is on that population level that Dr. Malampalli was just talking about, where we know there's so many people who have sleep apnea undiagnosed and they're missing out. They're living there for years and suffer potentially from sleepiness, high risk of car accidents, effects on their relationships. And they could be helped if they just knew about it, that they may have a problem and kind of seek that help. So I think this education that ASAP is doing is fantastic, is very important, kind of raising this awareness. Also, like Dr. Malampalli was saying, people who are screening, they often use stop bang. Male gender right there is kind of a risk factor. But again, it doesn't mean that women may have slightly different symptoms. So just being very attuned to that and kind of making sure that everybody gets a fair chance for an evaluation is important. The other side of that coin for me as a specialist is I think if someone kind of gets on this pathway, they are found to have sleep apnea and they're doing great, that's fantastic. But I think where it gets really tricky is like the people who, they have been diagnosed with sleep apnea and now they're failing like some standard therapy like CPAP. And now you have to kind of like think about like, okay, do I really want to go for like a surgery in order to try to treat this? And so I almost have like sometimes like these opposite discussions where we kind of really kind of go like take a close look at the data and we're like, yeah, on one side, yeah, sleep apnea has been associated with all these risks under the sun, but really like, the clear risk for like treatment benefits is really for symptoms and for blood pressure. We would be hoping that cardiovascular health improves and so forth, but, I don't really have super strong data. So if I have someone with like mild, moderate sleep apnea, they're relatively asymptomatic, maybe they even use CPAP, but they didn't really feel much better. I'm not sure I really want to push them down to like surgery, but I'm not sure that is really going to help them. So there's like kind of this really nuanced discussion on kind of also making sure that to understand that there's a realistic understanding of what the therapy can provide. But again, this is more like the specialist kind of side of things. I think for our audience or public health perspective right now, it's really more important to kind of be aware of like, the subtle symptoms and that there are potentially a lot of benefits from treating sleep disorders and getting people evaluated.
Great. Well, before we go to Dr. Martin with that same question, I want to ask you to clarify what stop bang is. You mentioned that, and I imagine a lot of people said, well, what the heck is that?
So stop bang, people over time have tried to come up with ways of helping people screen for sleep apnea in a standardized way. And so stop bang is probably like one of the most established screening tools, which I suspect a lot of providers on this call, if they screen patients for it, they probably use that or a variant of it. And so, it's basically like a eight questions, like including like, do you snore? Do you have like obesity? Are you male? And so forth. And so, depending on those scores, and if you have like a score greater than 3, you're considered high risk for sleep apnea. And so that's one way to kind of, operationalize it and kind of make sure that everybody gets screened. And generally, this is probably like a very well studied tool. But again, it does have the risk that, there's also people, unfortunately, or who don't meet those criteria. You certainly can have a woman who is like not obese and may not have like super strong snoring or something, but may still have sleep apnea. So I think, just because just because you don't score highly on this, I think, if there's like a sign that, someone may be struggling with their sleep, please still kind of get them evaluated.
Great. And Dr. Martin, any other communication or education things you want to mention?
Yeah, so I'm going to put my psychologist hat on and say that the vast majority of sleep apnea treatments that we have to offer people require them to do something every day. We know that adherence to things like antihypertensive medications is low. Maybe people take it half the time. Any of us who've committed to taking a multivitamin every day, I think we know how hard it is to even do something that simple. And so I think it's very important that that patients are realistic about their ability to use the treatments that they choose. And I think on the provider side, we should be more supportive and encouraging of people who use their treatment sometime. So this is a big challenge with CPAP-like treatments because Medicare has a threshold that they require patients to use their CPAP machine in order to keep it and continue to get supplies. You mentioned I also work in the VA system. We have no such rule. And a big reason why that's important is that we have a lot of folks with mental health conditions like post-traumatic stress disorder where their sleep time is actually quite short. And so, I think we always want patients using their treatment all the time. But I hear a lot of patients who come to me for help with CPAP adherence because their perception is that if they're not using it all the time, they're failing, and they're not. They're not failing, they're just not fully succeeding. So I think from a patient education perspective, treating your sleep apnea sometimes is better than not treating it at all, which is the choice that some people make. They just sort of give up. And as Dr. Schmickel said, they may not decide to pursue a second line therapy or they give up on CPAP. So that I think is very important. This is a very difficult health behavior for a lot of people. And I think we have to be compassionate about that. The second thing I would say is that really, again, circling back to something I said earlier, understanding what's important to the person in terms of choosing a treatment and continuing to use it. we actually are just wrapping up a study where we tried to help people get back to using CPAP who had used it in the past and then stopped. And the reasons that people stop using it are really varied. Sometimes it's like I went on vacation and I came home and I never started using it again. Sometimes it's because, a person changed insurance and, there were a lot of hurdles in the way to getting started again. So I think, from a patient perspective, just, it's not something that typically goes away. So, being committed that even if you sort of, have a lapse and you stop using treatment, that you get back to it again in the future. I like to tell my patients that when someone has been smoking cigarettes for a long time and they try to quit, on average, it takes 8 attempts before someone is successful. So it's not that we just decide to do something and we do it forever. It's okay. Keep trying, try again. If you fail, try again, but don't give up.
I love the perspective of they're not fully succeeding, but they're not failing. That's
Exactly.
an incredible perspective, I think, for
there's
health behaviors in general.
Yeah, one last thing that I will say is there's a lot of bad information out there. And I haven't heard it for a while, but putting duct tape over your mouth does not cure your sleep apnea. And there's a lot of ineffective and a few unsafe treatments out there. So encouraging patients to go to organizations like ASAP or the American Academy of Sleep Medicine or the American Thoracic Society, and making sure that the information that they're getting about sleep apnea is accurate and safe. So I think that, unfortunately, that's something that we're all up against.
Sure.
Jennifer, can I quickly just add something? What Chris was mentioning here about the stop bank, we know that doesn't work. It's been validated in primary care setting, but it does not work very well for women. And so there are efforts right now underway to come up with a screening tool for women. But if a woman scores negative on stop bank, doesn't mean she shouldn't. The physician still should try and make sure, listening to the symptoms that the woman is talking about, the clinical presentation is different with sleep apnea. Try and get them to at least still do a sleep study, because just by failing a screening question, it doesn't mean that they don't have sleep apnea. So that's one important point. I do also want to say, since we're on the topic of education, ASAP launched 2 years ago Sleep Apnea Education Week. We believe that there is enough awareness. So it is a social media awareness campaign, but there's enough awareness that sometimes people may not even take action. That's why we call it an education week, so we can actually promote education around sleep apnea. And that's from April 18th to the 26th. So 2026, this will be our 3rd year. I encourage GSA as well as all your members to definitely participate in this, because I think the more we spread the word around the need for education around sleep apnea, we can improve diagnosis, screening, as well as, treatment management for this condition.
Great. Well, that's super. Thank you for mentioning that. And where can people find your organization? What's the website they can look to?
apneapartners.org.
Great. Thank you. All right, Dr. Martin, you get my last question before we move on to Q&A, and we have a bunch of questions from the audience. So what other important points haven't we addressed that can help our interdisciplinary team that's on the line meet the needs of their patients with obesity and sleep apnea?
Yeah, I mean, I think one thing we haven't covered is that a lot of the treatments that we recommend, like physical activity, weight loss, avoiding alcohol, managing stress, help with obesity, help with sleep apnea, and also help with overall sleep quality. So I think in geriatrics, we love interventions that you do one thing and it has 4 or 5 different benefits. So I think this is an area where, again, just, the healthy lifestyle recommendations that we tend to make around physical activity, weight management, and we didn't talk about alcohol, but that does directly affect sleep apnea. It affects weight, it affects cognition. So thinking through, as a geriatrician or someone working in geriatrics, what some of the other recommendations you might be making that also might benefit obesity, sleep apnea, and overall sleep quality. So that's the only other thing I would add. I feel like we've touched on a lot of other really important things already.
Great. And Dr. Mellenpelli or Schmickel, anything else you want to mention before we move to audience QA? Okay. We've got a lot of them, so let's get going here. And I welcome any of you to chime in on these, knowing your expertise much better than I know who's best to answer. So the first question, how does the area of collapsibility differ in older women based on those who have obesity as opposed to normal aged women? And how does this affect a treatment approach and protocol?
Um, I don't know. That's a hard one, but and please feel free. Any of the other ones here on the panel to chime in or so. If I understand the question correctly, that it's about like does upper airway collapsibility change from a younger to an older woman? Is that right?
I'm gonna let you interpret it the best way
Okay.
possible. It seems
So,
Chris, you can open the Q&A if you want to read the question too.
okay.
I know I had to read it, I had to read it again. But I am curious, Chris, what your take is on airway collapsibility and how that would inform treatment decision making.
Um, I mean, I think the upper airway collapsibility generally with age does go up, and I think that is true for women just as in men. Whereas, like as Dr. Martin had mentioned earlier, like in women, it's just like whereas in men it's kind of more a linear change. I think over time, in women, it's just with menopause, basically, there's like a sudden step function increase, basically almost. And I think it's a combination of different things. Hormone levels obviously changed quite dramatically. And for example, progesterone is like a respiratory stimulant, which we think, for example, like, having a higher level of respiration kind of stabilizes your breathing. So, that's probably something that's protective. I wouldn't be surprised if like with menopause, there's like a, change in fat distribution, which again could like lead to maybe like more fat accumulation in the upper airway, which then make you more prone to collapsibility or so, narrowing that space and so forth. But to be honest, I'm not 100% sure. In terms of treatment approach, it's not. I think there's a lot of research going on trying to understand what's driving like in a given individual like their sleep apnea, and can we target that very specifically in kind of like a personalized precision medicine approach or so. But the reality is right now we're not there yet. Right now it's really still more like measuring do you have sleep apnea, and then kind of going through our treatment options and kind of having like this shared decision making about like, based on treatment goals, patient preferences, the data that we have. But, just because someone has a more collapsible area, I'm not sure I would change my management. And in reality, I usually don't really know this because I don't really measure like the upper airway collapsibility or so. I think maybe one more caveat there is that, it may play a little bit of a role there. Like, once you kind of get to second line options like surgery, that's when we really usually like you might, the ENT surgeon might take a very close look of like, okay, the upper airway anatomy, how is it? Where's the collapse happening? Which that could then inform like, are you a candidate for hypoglossal nerve stimulation? Do we think that, a UPPP or uvulopalatopharyngeoplasty, where the idea is you kind of create more space in the back of the throat, that you might be a great candidate for this or so. But that is really like the only situation where I can imagine right now that it really would affect your treatment approach.
Thank you. This next one, I bet you'll have a lot to say about. We have a couple of questions about using apps, Oura Rings, Apple Watches, all kinds of other tech that we are all loving. How reliable is that for really tracking sleep? And is it giving people false assurances, so kind of false negatives that offer them reassurance that they're sleeping just fine? So any thoughts about those?
Well, so I see a full range of reactions to people's sleep data. One of our colleagues, Soft One Batter, he always says that he likes to wake up in the morning and look at his Oura Ring and see how he should feel that day. So I think that there are some people that give a little too much credence to what their wearable is telling them. Specific to screening for sleep apnea, I think we can say with a lot of confidence that people cannot rule out whether they have sleep apnea or not based on the data from a consumer wearable. If somebody's wearable device suggests that they do, they should see someone and get evaluated. The reliability of the estimation of sleep is a moving target. The algorithms and the data that they use are changing all the time. It's getting better, but I don't know that it's quite as accurate in people who have sleep disorders as it is in people who are healthy, normal sleepers. I like to use wearables for accountability. So if I'm working with somebody, for example, who isn't getting enough sleep, I think keeping track of your time in bed to make sure that you're getting adequate sleep, that can be really good in terms of behavioral monitoring. But I don't tend to invest a lot into whatever that sleep score is that my Garmin tells me. I don't know what it means. I don't know what goes into it. And ironically, it does tell me what to do that day, but I don't know what that's based on either. Am I supposed to exercise or rest, or who knows where all that comes from? But I think the most important thing, again, for today's topic is if your wearable tells you you don't have sleep apnea, we have no evidence that that is an accurate assessment.
I think it's a good start. I think, like Dr. Martin said, it holds you accountable. But if you're measuring anything, and definitely have that conversation with your doctor. Say, what does that mean? But I do want to add that we have an article on this topic under a blog section at apneapartners.org. And I think you'll find more information on the topic of pulse.
Great. Feel free, Dr. Malampalli, to chat. If you have that easy, feel free to drop it in chat too. We welcome you to do that. Okay. Some of you have mentioned a bit about mood and cognitive abilities, and that they may change when an older adult has sleep apnea or other sleep disturbances. And I wondered if you could just dive a little more into that and kind of, where that if I'm looking at someone maybe for investigating impaired cognition or something along those lines, where we could dig into that a little more.
Well, maybe I'll start by saying that having any untreated sleep disorder is not good for your brain health, and it's not good for your cognitive abilities. There's some data that when you treat sleep apnea in patients who have mild or moderate cognitive impairment, that their cognition does improve. It doesn't cure their underlying dementia, but it does improve their cognition, reduce sleepiness during the day. So there was actually a randomized controlled trial done at UCSD where Dr. Schmickel practices, demonstrating that. So we shouldn't ignore sleep disorders like sleep apnea because a person has cognitive impairment. And we do know that untreated sleep apnea or any sleep disturbance in general is not good for cognitive functioning. I'm curious if the two of you have anything you want to add, but again, an important take-home point is the presence of dementia doesn't mean we ignore the sleep issues. Just means we may have to think about them a little differently, and how we incorporate treatment may depend on how independent the person is in their ability to use the treatment versus how much do they rely on a caregiver or support person.
Yeah, no, I think that's a really good point that you make there, Dr. Martin. And I think in my practice, I certainly offer it to patients where there's some concerns about this. I think that one important thing I want to add on just is that, these clinical trials, for example, they show you like an average effect. So yeah, on average, maybe like, cognition improved and daytime alertness improved or so. But I think the important thing is then to have follow-up and actually see what happened to your individual person. Like, if they feel better, great. But if now, like, they're actually like worse off because now again, like, maybe it disrupts their sleep quality wearing that mask, and, like the caregiver is kind of all tired because every hour they have to get up and readjust it and whatnot, then for them, it's probably not the right approach, or maybe there's like something that you can troubleshoot. But I think paying attention to the individual results is very important in that setting. And I guess the other part is, also just not making sure there's realistic expectations. So I guess you already said, like, it's not going to make the dementia go away, but it may help improve like the cognition, on a day-to-day level to some degree or so.
Great. I think we have time for one more question, and let me see. I'd like to learn about this from each of you. What really that is on the horizon for treatment of OSA and obesity that excites you?
And I can maybe jump into that and then have others add on.
Please.
I think, part of the reason why I became a sleep doctor is because initially I saw like, I still remember like when I first walked into a sleep clinic, I saw some patients, with coming back with CPAP, and they were like, oh my God, this completely changed my life. And then on the other side, I saw like a bunch of patients come back and they were like, how can anyone sleep with this? I'm still miserable, but how can anyone wear like a CPAP mask? And so I was like, okay, this is a really fascinating area. Lots of people are affected, can have a huge impact on your life, but the treatment options are quite limited. And that was like about 10 years ago. And so now, like just in the last 10 years, so much has changed. We have like the CPAP, the oral appliances, we have like hypoglossal nerve stimulation. There's like 2 other hypoglossal nerve stimulators who are getting approved soon. There's like a lot of research going into medications, which are not quite like medications that don't address the obesity, but are specifically trying to target sleep apnea, which is not ready for prime time yet. But I wouldn't be surprised if in the next few years that becomes a treatment option for select patients with, you know, some caveats and so forth. And then now we have like, I think the biggest change like was like a couple of years ago now, like, you know, this weight loss medications where right now the main one is tirzepatide, which is an injectable once a week. Very effective. People on average lose about 20% of weight, which on average improves like sleep apnea severity by 55%. And in my, you know, has like also a lot of benefits, obviously beyond just sleep apnea. And so there's a lot of development now going on trying to come up with similar medications that are either more effective, maybe even more weight loss, or they're easier to use, maybe like some oral formulations and so forth. So I think in the next few years, we will see like a whole range of new medications in that space coming out that will be of a lot of value for our patients with sleep apnea as well.
Terrific. With that, I am going to mention that we are at time. We're actually a minute over. This has been a fascinating discussion. I can't thank you all enough for joining us. And again, thank you for the Alliance of Sleep Apnea Partners for being our partner in this. And I'd want to again acknowledge our colleagues at Lilly for their support as well. And thank you all for joining us. I hope you found the program useful, and please share it with your friends that it's available in the GSA Enrich platform with no charge or anything for them. So thank you all so much for joining us today. Take care now.
Thank you very much.
Bye-bye. Thank you.
Bye-bye.